Hello everyone. Today I will be discussing about peripheral arterial Doppler, that is mainly lower limb arterial Doppler. The most important thing in any examination is taking proper history. Ask for any history of chronic medical illness, chronic hypertension or diabetes mellitus. Ask for any complaints of resting pain, claudication pain, ulcer or gangrene. Palpate all the pulses of the limb you are going to examine. Measure ankle brachial index. It is the ratio of blood pressure that is taken at the ankle level to that of the cubital fossa. Normal ankle brachial index is more than 1. When it is less than 1, it indicates there is ischemia. Falsely high level of ankle brachial index is seen in rigid and calcified arteries. We can also measure segmental pressures at the thigh level or at the leg level. Pressure difference between two levels more than 20 mm of mercury are considered abnormal. There are so many nomenclatures are used to describe the waveforms in arterial Doppler. You can go through this wonderful article which is published in International Journal of Vascular Medicine and Ultrasound in 2020, which has described wonderfully the uniform nomenclatures to be used to describe a waveform in Doppler. Apply rule of 3 in when doing Doppler. Answer these three questions. What is the site of stenosis? What is the severity and are there any collaterals? Look at the three sites. Pre-stenotic site, that is upstream, at the site of stenosis, and downstream, that is post-stenotic site. Take velocity and waveforms at three sites. Pre-stenotic site, that is A, at the site of stenosis, that is B, and post-stenotic site, that is C. The velocity ratio is the ratio between the pre-systolic velocity at systolic to that of pre-systolic site. Knowing which vessel we are imaging is very important because monophasic waveform, which is normal in renal arteries, is abnormal in lower limb arteries, and high resistant waveform, which is normal in lower limb arteries, is abnormal in carotids. Again, you have to see three things while doing Doppler, that is waveform, velocity and spectral window. In the waveform, again look for three things: flow direction, phasicity and resistance. Flow direction. Antegrade flow is when the blood flows in the proper or the correct direction in the vessel we are examining. And retrograde flow is when the blood flows in the opposite direction abnormally below the baseline. Bidirectional is when the blood flow in both the direction, antegrade as well as retrograde, through the same orifice. In absent, there is no blood flow across the vessels. Phasicity. These two waveforms were used to describe as being triphasic, the above one, and biphasic, the below one, in previously. So now these two waveforms are described as multiphasic. It has systolic peak, early diastolic reversal and late diastolic forward flow. In monophasic waveform, we have the flow only above the baseline. Monophasic waveform can be normal and as well as abnormal. If the monophasic waveform has tardus parvus pattern, that is if it has slow uptake and weak amplitude, it is abnormal. Whereas a monophasic waveform having strong or sharp systolic upstroke is normal. High resistant waveforms will have rapid upstroke and downstroke with or without diastolic flow. Intermediate resistant waves have end systolic notch with continuous diastolic flow above the baseline. The low resistant waveforms have prolonged downstroke in late systole and continuous forward flow. Spectral broadening. It is the widening of the velocity band with filling in of the window. Staccato waveform. It is a very high resistant pattern with short spike of velocity acceleration and deceleration. Usually these type of waveforms are seen in the pre-stenotic site when there is very tight stenosis distally. Dampened waveforms will have very low velocity, slow upstroke waveforms. The reversal of the flow, we see abnormally reversal of the waveform below the baseline. Again remember three velocities in the lower limbs. The femoral artery will have normal velocity around 80 to 100 cm per second. Popliteal artery around 60 to 80 cm per second and ATA PTA around 40 to 60 cm per second. The normal resting inflow arteries like iliac arteries will have antegrade multiphasic waves showing high resistance. The normal resting runoff arteries will have antegrade multiphasic waveforms showing high resistance. There will be mild spectral broadening. This is due to mild reduction in the lumen of the vessels. The normal resting palmar, plantar or digital arteries will have antegrade multiphasic high resistant waveforms with mild spectral broadening. Again, this is due to smaller size of the arteries. The intermediate resistant waveform can be seen normally in cases of post exercise or if we do the Doppler immediately after the exercise or when the body temperature is increased. It can be abnormally seen in cases of inflammation or in pre-stenotic site when you see non-flow limiting stenosis distally. We'll see some of the pathologies in the arteries. Always include abdominal aorta in the imaging as it may be affected by aneurysm, plaques, dissection and collaterals which may affect the distal vessels. The common causes of arterial diseases are atherosclerosis, which is the most common cause, thrombosis, aneurysm, intimal dissection, pseudoaneurysm, fistula, arteritis, entrapment syndrome, etc. This is the image of gangrene of the digit. Again remember three grades of stenosis: less than 50% stenosis, 50 to 75% stenosis and more than 75% stenosis. In less than 50% diameter stenosis, the velocity ratio, that is the ratio of peak systolic velocity at the stenotic site to the pre-stenotic site will be less than 2:1. The reversal flow, which is below the baseline, will be present. There will be mild spectral broadening. When the stenosis is between 50 to 75%, the velocity ratio will be more than 2:1. The reversal flow will be either reduced significantly or absent. There will be spectral filling. When the diameter is reduced more than 75%, the velocity ratio will be more than 4:1. In this image, you can see the peak systolic velocity is more than 400 cm per second. You will get monophasic waveform. There will be spectral bruit at the base and the diastolic velocity will be increased. In this, the diastolic velocity is more than 100 cm per second. These waveforms we see at the stenotic site. In the pre-stenotic site, if the distal stenosis is not flow limiting, we see high or intermediate resistant waveforms showing rapid upstroke. If distally there is flow limiting stenosis or tight stenosis, we see staccato type of waveforms. So whenever you see these waveforms, be careful in searching for very tight stenosis distally. Distal to the occlusion, we will get dampened monophasic waveform showing spectral broadening. Depending on the collaterals, the waveforms what we get in the vessels in the distally will be, if the collaterals are very well developed, you see very low amplitude low amplitude triphasic or biphasic waveforms. If the poor collaterals are developed, you will get monophasic waveforms. If there are no collaterals, that means there won't be any flow distally. In case of pseudoaneurysm, we see bidirectional flow through the neck. You see rapid systolic upstroke, elongated prominent reversal flow. This is the Doppler image of pseudoaneurysm showing yin-yang sign. In case of arteriovenous fistula, the blood flow from high pressure artery to low pressure vein. You see spectral broadening with elevated velocities in the artery and vein. Thromboangiitis obliterans or Burgess disease. It is non-atheromatous inflammatory disease most commonly seen in smokers. It involves medium to small sized vessels. Commonly involves upper limbs or distal leg or foot. The vascular wall will be hypoechoic without calcification. There will be alternating normal and abnormal segments of occlusion. You see characteristic corkscrew shaped collaterals. This is a clinical image. In this, you see in the right upper side there will be occlusion of the PTA without any calcification. In left upper image, you see inflamed venous wall. Lower image show the collaterals which are in corkscrew shape. Depending of the size of the collaterals, it can be type 1, type 2, type 3 or type 4. Sonography is recommended for non-invasive technique for the post-operative monitoring of bypass graft patency. The normal peak systolic velocity in case of bypass graft can vary from 45 to 180 cm per second. In the immediate post-op period, we can see monophasic hyperemic flow. Over the time, the flow normally assumes a pulsatile flow. The causes of graft failure are either technical fault, neointimal hyperplasia, atherosclerosis or graft degeneration. We have to look for stenosis at the proximal anastomotic site, distal anatomic site or graft conduit. Again, you have to measure the velocity ratio. The compartment syndrome. In compartment syndrome, you see very gross soft tissue edema with pan reversal of the flow. Whenever you report a peripheral artery Doppler, include all these things. Any non-imaging physiological tests like ankle brachial index. Answer: is it an arterial problem or venous problem? What is the site or sites of disease? What is the severity of the disease? Length of the lesion, if collaterals present or absent, nature of the disease and status of distal vessels. That completes arterial Doppler of lower limb. Thank you.